All right. Welcome back, everybody. Thank you for coming out tonight. We have another great discussion for you tonight. We are going to be talking about dysphagia or swallowing disorders, and we have Dr. Jordan Hazelwood here to speak to us. Dr. Hazelwood is an associate professor in the Department of Communication Sciences and Disorders at Appalachian State University in Boone, North Carolina. Before completing her PhD in Health and Rehabilitation Sciences at the Medical University of South Carolina in Charleston, South Carolina, she worked as a speech-language pathologist specializing in the assessment and rehabilitation of adults with swallowing disorders and traumatic brain injury. Dr. Hazelwood teaches dysphagia, voice and resonance disorders, and neuroanatomy and physiology to graduate and undergraduate students. She is a board-certified specialist in swallowing and swallowing disorders, has served as the professional development manager for ASHA's Special Interest Group in Swallowing and Swallowing Disorders, or SIG-13, and has earned fellowships in clinical research ethics and interprofessional education. Her research focuses on the training and education of clinicians and students in dysphagia management while considering the impact of standardization procedures, physiologic dysfunction, and quality of life on health outcomes. With that, thank you, Dr. Hazelwood, for coming out, and I will turn everything over to you.
All right, thank you so much, Zach. Good evening, everyone. I am glad to have you here. I am pretty comfortable with teaching on an online platform on Zoom, but I would just let you know that if you are comfortable, even though we're being recorded, if you're comfortable being on camera and interacting with me on the chat, whatever makes you feel the best would be awesome. And I would love to, I see your names there, but I would love to have you enter in the chat where you're from. And if you are in your first year of your graduate program, in your second year, and you're just about to take the praxis, I'm trying to figure out what exactly everybody's level of interest is. If you don't mind, that would be super great. And where you're from. So as Zach said, I'm in North Carolina. We had our first snow yesterday, first snow day, I should say. So it's really starting to feel like winter here as we move into the holiday season. So it looks like we have some people that are also in cold weather and some other people that are in warmer weather. Kelly, I am also from Illinois, so I'll give you a special shout out and hello from the Midwest at Wisconsin. It's good to see you all here. So thank you, Minnesota as well. So glad to have you all here. If you would like, as we go throughout the session, please feel free to ask questions in the chat. Zach's going to be helping me monitor the chat because in just a minute when I share my screen, I'm not going to be able to see it too well. But then we'll also have an opportunity for questions and answers at the end. And I am also available via email. And you'll see that I put my Instagram handle on my name, so you can catch me that way as well. So let's go ahead and get started. All right. So let's see here. I say this and then my Zoom gets all messed up when I try to share my screen. So hold on, let me switch things around here. It's kind of like driving an airplane or flying an airplane, I should say. Making sure I can get everything situated here. You know what, y'all, I'm at home today because my kiddo is sick and I'm having some Zoom issues. So let's just do it like this. Cool. You can see things in the background. It's not going to kill you. How's that? Everybody good with that? Can I get a thumbs up if you're feeling all right? You can see that okay?
Yes, we can
Zach?
see it.
Yeah, cool. Thanks for the feedback. I appreciate the feedback. All right, everybody. So let's rock and roll. So y'all are all in your second year, about ready to hunker down. I teach students in your exact same situation. So I know that you are stressed to the max right now. And I want to just let you know that you've got this. And the praxis is one of those professional hoops, I guess you could say, that you have to jump through that. But once you jump through it, you're kind of like, why did I have so much stress about it? Okay. So just so you know, you'll be able to make it through. So let's talk about dysphagia today. Okay. The reason I have been asked to give this talk is because I authored one of the chapters in the Therapy Ed Office Hours Praxis Study Guide here. And so the office hours is to help you be able to go through each of the different big 9 and some of the other sub big 9 areas that we have as speech language pathologists. And just so you know, Therapy Ed will have these recordings on their YouTube channel if you want to take a look at that, as well as some other topics if you want to review. Okay. So as you may or may not know, but at this point in the time, you're probably pretty familiar with the idea of dysphagia, which is difficulty or discomfort in swallowing. And Several signs and symptoms that come up with dysphagia include coughing, gagging, weak mastication, or odynophagia, which means pain upon swallowing. Just as a reminder, signs are things that you can see, and symptoms are things that are reported by the patient. So those are a little bit different, even though we typically use them side by side or interchangeably. They are slightly different in their actual meaning. And the reason we care about dysphagia so much is because there's so much negative consequences that can result from dysphagia, including malnutrition, dehydration, and decreased quality of life. And being that SLPs are the preferred healthcare provider for dysphagia management, it is really important that we understand what this looks like. So we're going to start by talking about our normal swallow and what that looks like from a physiologic standpoint in the head and neck. Then we're going to move into central swallowing control, what that looks like from the central nervous system and peripheral nervous system. And then we're thinking about disorders of dysphagia and how we manage that through treatment and assessment. Okay, so what does the normal swallow look like? So in summary, we have a bolus that you see here in green, which is food or liquid particles that have been masticated or manipulated in some way and mixed with saliva, so that we have both mechanical and chemical digestion that starts at the mouth, and it moves its way from the lips all the way down through the lower esophageal sphincter into the stomach. And from there is basically where the GI specialists take over, and we are out of our scope of practice at that point in time. But when we think about a bolus entering into the mouth, we have to get it there somehow. So we think about our occupational therapy and physical therapy friends who help us with rehabilitation of the upper trunk and the arms and the neck in order for patients to be able to feed themselves. We also think about the impact of cognition, eyesight, balance, and other sensory aspects in order for us to fully appreciate what it means to eat and drink. So while we typically think about swallowing in phases, there is this what we call anticipatory stage, where we get ourselves ready to eat and drink, where we are salivating, we're smelling, we're looking at our plate, we're anticipating what things are going to smell like. Our motor plans are setting themselves up for whether we're going to take a big bite, a small bite, depending if the food is hot or cold, or if we're eating a steak or an apple, whether we have chopsticks or a spoon. All of those things are going to really impact what's going on even before the food or liquid hits our mouth. So all of those things are happening because we use all of our cranial nerves when we eat and drink. But from here on out, we're really just going to be thinking about a specific set of muscles and cranial nerves that happen to be in the head and neck. But I don't want you to forget about the sensory input that is very important as we begin to think about the actual experience of eating and drinking and what that means as it pertains to patients' quality of life, as well as the human experience of actually engaging in a mealtime activity. Because what do we do when we celebrate? What do we do when we're down? We eat and we drink, right? So all these things are what make us be human. So that's why really understanding about swallowing is so very important. And as we think about the bolus moving from the lips, we will begin to masticate it with our teeth and move the jaw and the lips and the tongue around so that the bolus can be manipulated. And that's typically what we consider to be the oral preparatory stage, where we're preparing the bolus after it has entered into the oral cavity. And once the bolus is prepared, it's chewed and it has been coated in saliva. That is when the bolus is going to move anterior, posteriorly from the front of the mouth to the back of the mouth so that it can enter into the hypopharynx and down into the pharyngeal cavity, which is what you're noticing here. And during that stage of the game is when we have closure of the airway, both the upper airway in the nasal cavity and the beginning of the lower airway in the laryngeal system, all closed off so that the upper esophageal sphincter can open and the bolus can pass through into the esophagus, make its way down the esophagus and enter into the stomach for further digestion. So that being said, let's talk about those stages as we go through the rest of the slides in a little bit more detail. But one thing I really want you to think about while we're talking about these stages is the really important information or fact about the fact that these stages are not discrete. They're not like dominoes where one happens and then the other one happens and then the other one happens. They don't knock each other down. These things are actually happening very synergistically all at the same time. In fact, as we're chewing and preparing our food, our esophagus is starting to get ready to go. We notice that if we have things like acid reflux, that our pharynx will actually compensate and try to do some maneuvers to keep any acid that is coming up from underneath down. So all of these systems together are working simultaneously, which is why it's really important to think about not swallowing in stages, but actually how the whole mechanism works as a whole, even though I'm about to teach it to you in stages. So I hope that makes sense. So we think about anticipatory stage first, getting ready and prepared to eat. Then we move into what's called the oral prep stage. And during this stage, this is a volitional stage of swallow. And depending on what you're eating, the time it takes to have this stage be completed is dependent. So once the food is in the mouth and it's prepared for swallowing, you want to make sure that your lips are closed and you will no longer be able to breathe out of your mouth because at that point in time, you have everything closed off. So you don't have anterior spillage of the bolus out of the mouth, but you will still be able to breathe out of your nose because your soft palate is down and your nasal cavity is clear. So the main things that are happening during the oral prep stage is mastication. And if you recall, cranial nerve 5, the trigeminal nerve. And as a reminder, this might be a little bit of a review for you. Trigeminal, if you think about germinations or branches, there's 3 of them and they run this way on your face. So trigeminal is cranial nerve 5. It innervates the muscles of mastication. Now, the 3 branches of the trigeminal nerve have sensory on branch 1, sensory on branch 2, and sensory and motor in branch 3. So branch 3 is mixed, if you will, for its function. And so this the 3rd branch right here that is responsible for chewing or mastication. And it does that through its mandibular elevators, the masseter, temporalis, and pterygoid muscles, and the depressors, which are the mylohyoid and the anterior belly of the digastricus muscle. Now, along with chewing, we also have salivation. And this is really important in order to be able to have food broken down as well as coating in the bolus so that the bolus can be very smooth and slick as it moves down into the hypopharynx. Now, because we have water and enzymes in the secretion that comes out of the glands, that means that the chemical breakdown along with the mechanical breakdown from chewing can also begin to start the digestion of the bolus. Now, what you'll notice here is that we have 3 salivary glands, and the way that they're organized is very similar to how we think about the organization of the taste sensory factors from cranial nerve 7 and cranial nerve 9. If you recall that cranial nerve 7 and 9 are both responsible for taste in the tongue, and the anterior 2/3 of the tongue are responsible for taste coming from cranial nerve 7, and the posterior 1/3 is responsible for taste through cranial nerve 9. So if you think about this, when you write cranial nerve 7 as a Roman numeral, you have a 5, and then you have a 1 and a 1. So if you think about that, it's 2, so 2/3. And when you write the cranial nerve 9, you write a 1 and an X, so it's 1/3. And then when you think about the order in which those occur, 7 comes before 9, so you have 7 in the front, 2/3, and then 9, 1/3 in the back. So the anterior 2/3 is by cranial nerve 7, which is the facial nerve, and the posterior 1/3 is cranial nerve 9, which is the is the glossopharyngeal nerve. Now the glossopharyngeal nerve, the glosso part is the sensory aspect, and the pharyngeal part is the motor aspect. Okay, so thinking about the sensory aspect, though, we have the 2/3 anterior tongue sensory for taste is cranial nerve 7. These are also 2 of the 3 salivation glands are innervated by cranial nerve 7. The other 1/3 of the salivation glands are innervated by cranial nerve 9. So let's take a look at what this looks like on this picture. We have sublingual, which is right here underneath the tongue, submandibular, which is here under the mandible, and parotid, which is here up underneath the buccal and masseter muscles, kind of in between where you are entering into the temporalis region for the ear. So right here, anterior 2/3, these 2, sublingual, submandibular, are innervated by cranial nerve 7. And here, the posterior 1/3 is innervated by cranial nerve 9. Okay, so we have chewing. Let me go back before we moved into oral stage. For oral prep, we have chewing and salivation. Okay, so the bolus is ready to go. We're ready to move it back. And so now that moves us into the oral stage. Now, this again is still a voluntary stage of swallow, just like the oral prep stage was. It, however, does not depend necessarily on what you're eating, because by this point in time, the variation in what you're eating is accounted for in the oral prep stage because the bolus has already been prepared and ready to go. So this stage, the oral stage, usually lasts about 1 second. And it usually starts once mastication finishes, and the tongue will form a ramp to be able to move or propel the bolus from the front of the back, from the front to the back of the oral cavity down into the pharyngeal cavity. And what we need to be able to have happen here is the lips need to stay sealed, and then you need to be able to continue to breathe out of the nose. Okay, so for this labial seal, in order to keep the bolus from moving anteriorly and providing that positive pressure in the oral cavity to move the bolus back into the mouth and down through into the pharynx, we have to have some control of our facial muscles, including the lip muscles, which are all controlled by the facial nerve. Facial nerve provides taste to anterior 2/3 of the tongue, as well as motor to the facial muscles. Now, the main lip muscle that we think about for lip seal is the orbicularis oris muscle, and we want to make sure that that is intact before we are allowing our patients to have anything that might actually creep out the front and have that anterior spillage. The other part of the oral stage that we want to think about is the tongue retraction. This is going to be really helpful for the trigeminal nerve as it helps move the tongue back, as well as the hypoglossal nerve, which is cranial nerve 12. Now, the two muscles that are going to be controlled by the trigeminal nerve are the digastricus muscle as well as the mylohilo muscle. These are really going to be helping to form that ramp that moves the tongue from the front of, or moves the bolus from the front of the back to the back of the pharynx. So this anterior posterior movement that I just described, here it is the hypoglossal nerve, cranial nerve 12. That's going to be really helping to form the intrinsic and extrinsic muscles of the tongue. Now, just as a reminder, intrinsic muscles means that the insertion and origin are both on the same structure, whereas extrinsic means the insertion is on one structure and the origin is on another structure. So the intrinsic muscles of the tongue include the superior longitudinal, the inferior longitudinal, the transverse, and the vertical, and they all work like this kind of interwoven machine, and we call it a hydrostat that allows the tongue to be able to move, push, pull in all these different directions. Then we have, those are all the intrinsic muscles, those four. Then we have the extrinsic muscles, which all attach somewhere onto the tongue and then go somewhere else. So an example is the genioglossus or the hyoglossus or the palatoglossus. Keyword here is glossus. If it has glossus in it, it is attaching to the tongue and it's going to be going somewhere else. That would be an extrinsic muscle of the tongue. So all of these muscles help to shape and form the bolus, as well as to move the bolus from the front of the back to the back of the mouth while squeezing along the top of the anterior portion of the alveolar ridge from the hard palate and back into the soft palate. And so what this is going to look like as we move the bolus from front to back is the lips are sealed here, and we have the beginning of this tongue ramp where the tail of the bolus is being pushed on by the body of the tongue, and the base of tongue is moving forward in order for the bolus to be able to fall into the pharynx. Now, what's really important to think about here, though, and this is where safety concerns become an issue for people that actually have dysphagia, is that we have an open airway, right? So we are still breathing nasally. We have a patent airway this way, and the laryngeal passageway is still wide open. So there is breathing that is able to happen at this point in time. So if you do have a posterior loss of the bolus, or what sometimes is described as posterior, what's sometimes called premature spillage into the pharynx, this is where you can end up with penetration or aspiration before the swallow is occurring. So we've talked about anticipatory stage so far, where you're having your sensory information and forming what your motor control is going to look like once you begin to feed yourself. You have your oral prep stage, where you are masticating and salivating, getting the bolus ready and prepared to go. We have the oral stage, where you're going to seal your lips and form a tongue ramp to move the bolus from front to back. And now we're going to be moving into the pharyngeal stage. So the pharyngeal stage, while the oral prep and oral stages are voluntary, the pharyngeal stage is essentially involuntary. Sometimes you can exercise voluntary control, but depending on how far deep and what type of bolus you are actually trying to swallow will determine if you are able to actually control how far and deep it goes before you lose that voluntary control. The pharyngeal stage, just like the oral stage, lasts about 1 second. And if once the bolus contacts the fascial pillars, it begins this series of events that allows the vocal folds and the larynx to close off, as well as to close off the nasal passage, so that everything at that point in time is closed. You're no longer able to breathe, and everything is moving up and forward so that the esophagus can open and the bolus can fall with the aid of gravity into the esophagus. So there's this cascade of events that occurs, and we'll talk about what that looks like right now. Okay, so first thing is that the soft palate is going to elevate. And the really important part about this is it helps keep food or liquid out of the nasal cavity. If you've ever laughed while you're eating or drinking, you had food come out of your nose, you know how very uncomfortable that is. It's not supposed to happen that way. And so what we really think about is that the soft palate needs to elevate to be able to close off the airway so that it can remain safe and free from any type of irritants, including food or liquid. When we have the soft palate open and close, that can be seen when we're doing a cranial nerve evaluation or a clinical swallow evaluation, which is one of the reasons why we ask our patients to say ah, 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 and we're looking for the elevation of that muscular uvulus complex. And these are several of the muscles that are involved. And what you'll notice here is that we have cranial nerves 9 and 10 and 5 that are involved. So this is the pharyngeal complex, as well as cranial nerve 5, the trigeminal nerve. So the tensor veli palatini, the palatal glossus, that's one of the extrinsic muscles of the tongue, the tensor veli palatini, the musculus uvulus, and the palatopharyngis. They all help to pull up, constrict, close off, raise, do some type of muscle movement of the soft palate. And I want you to want to think about the soft palate is just a really tiny valve, but around it we have several U-shaped muscles like this. So we want to be able to have constriction on that soft palate around this way, as well as meeting it forward so that there is no space in between where the palate is on the back of the posterior pharyngeal wall. So it really needs to be closed off nice and tight. And if we don't have if we don't have a good tight closure of the soft palate, then we end up with hypo or hypernasality, a lot of those motor speech quality characteristics that you might hear in a dysarthric speech. So that's one of the things that you want to think about when you are doing a cranial nerve evaluation, is to evaluate speech quality as it pertains to nasality. So soft palate closes. The other thing that happens is we have a laryngeal closure. And what we have here is 4 valves, again, along with the soft palate valve. We have the 4 valves of the larynx to be able to close off the airway to protect the bolus from entering it. So what I'm going to do is I'm going to show you what I call my students. I'm going to show you a quick little dance. So we have the true folds close, the false folds close, the arytenoids move forward, and then the epiglottis moves back. So it's true folds, false folds, arytenoids anterior, epiglottis posterior. And so while I have these in order 1, 2, 3, 4, these are actually flipped over. Inferior, most inferior are the true vocal folds. They need to close. They are inferior and medial to the false folds. The false folds are superior and lateral, but they also close, or those ventricular folds, that's the same name, right? Then the arytenoids are going to move forward to where the epiglottis, or that petiole of the epiglottis, is right inside the beginning cartilage of the thyroid. And then the epiglottis, that petiole, is that breaking point right there. It's going to close over top. So from the side, we have true folds, false folds, arytenoids move forward, and the epiglottis moves back. So we have several different valves that help close off the larynx to be able to ensure the laryngeal vestibule, or the inlet, or the airway, whatever words you want to use there, is sealed off and closed. Now, the other thing too that we think about, as the soft palate's closing, the larynx is closing, doing all these 4 valves, it's also going to be lifting up. So the laryngeal complex, which is all the cartilages along with the hyoid bone, are going to elevate, and that elevation is happening from the suprahyoid muscles. So you think about all the muscles that attach to the hyoid and that are moving above the hyoid. So anterior digastricus, mylohyoid, stylohyoid, the posterior belly of the digastricus. Those are all going to be helping to elevate the larynx up as well as move it forward. And in doing that, it moves the larynx out of the way of the pharynx. So the bolus has a way to pass back into the pharyngeal cavity. And it also helps to move the stretching or elevate the stretching of the upper esophageal sphincter muscle so that the bolus can enter into the esophagus. But the bolus doesn't just fall down with gravity. Gravity helps it, but it also needs a little bit of help from the pharyngeal constrictor muscles. So again, when we were talking about the soft palate, and I said there are these U-shaped muscles that come around from the side, right, to help close in on that soft palate. These are the muscles. We have a superior, middle, and inferior pharyngeal constrictor muscles. And I keep doing like a U shape, but if you imagine giving someone a neck rub right from behind, choop, 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 we have these muscles that are U-shaped, and then the soft palate is like this from the front. Okay, I hope you can kind of see what I'm trying to do here with my hands. Those muscles, the superior, middle, and inferior pharyngeal constrictor muscles, are going to be squeezing from lateral to medial. So they're going to be squeezing in like this, and they also are going to squeeze from back to front this way. So they're kind of doing this kind of motion in the pharynx to help the bolus move down as the soft palate's closing, the larynx is closing and lifting up while those pharyngeal muscles, superior, middle, inferior, are going to squeeze the bolus down. And in doing all of that, we end up with the bolus right here in the piriform sinuses. Now, remind yourself just from the posterior view, as the bolus comes over the base of the tongue, it may or may not sit in this space right here between the base of the tongue and epiglottis called the vallecula. Then it will possibly bifurcate and go around that laryngeal inlet. It may or may not flow directly over the top of that closed. Remember, we have arytenoids this way and epiglottis this way. So the bolus may flow over that closed epiglottis, but it also may bifurcate and go around the epiglottis down into what we call the lateral channels or the piriform sinuses. And it will land or collect, pool, whatever word you want to use, right in this area above the upper esophageal sphincter. And again, this is the posterior pharyngeal wall, which is going to move forward in those three sections. And it's also going to contract lateral to medial as we move the bolus down the pharynx with the assistance of gravity. And so once we get to this stage where the bolus is hanging out in the pharynx, and again, this happens super quickly. This is one of the reasons why I love this so much, because there's so much dynamic action that's happening and it happens so quickly. Once we get here is when the esophagus starts to become involved, okay? So this upper esophageal sphincter right here is the area where we think about a valve. And this is where we have a completely involuntary stage of swallowing. Depending on how big you are physically, right, how long your esophagus is. Also, depending on what kind of food you've eaten, how quickly you've swallowed it, if you've had multiple swallows or one swallow, all of that will depend on how long this stage of swallowing actually takes. Again, similar to the posterior pharyngeal wall, the superior, middle, and inferior constrictor muscle, where they're squeezing the bolus down, the esophagus, the esophageal stage specifically, is responsible for providing peristalsis, which is a squeezing contractile motion that's very much like, I've got a couple of analogies. One, squeezing toothpaste through a tube of toothpaste, right? Squeezing that out. Another one is if you think about a snake eating a large meal and it's moving that meal through its body. Or my favorite is an animal balloon, right? So you've all seen those really long, stretchy balloons where someone blows it up. And then if you just have a little bit of air in that animal balloon, you can move the air back and forth, okay? So peristalsis is what allows the bolus to not just like bloop, slide down or get stuck in the esophagus. It allows through a muscular movement controlled by cranial nerve 10, the vagus nerve, to actually move the bolus down through the esophagus. So let's talk about this upper esophageal sphincter. This is the same area that is considered to be the CP muscle. You might have heard of a CP bar that we can see on a modified barium swallow study or video fluoroscopy. The cricopharyngeus, or the CP muscle, is a muscle that is innervated by cranial nerve 10, and at rest, it is contracted. It's called a tonic muscle. And we have one at the beginning of our esophagus. This is the upper, and we have another one at the bottom, and it's the lower. So we have the UES, upper esophageal sphincter, and the lower, the LES. There is one more all the way at the bottom of the digestive tract, which is also a tonic muscle. And these are the muscles that we hope stay closed for good reason. Otherwise, we'd have a lot of problems if we're trying to walk around or if we're trying to bend over, right? Otherwise, food and liquid would be just coming in and out of our bodies all different directions. So these muscles have to stay closed. So when they relax, these are the muscles that actually open up. And when they relax and they open up, that allows the bolus to flow through, okay? So once the bolus gets here at this stage where the upper esophageal sphincter is ready to be opened, it opens in a couple of ways. One, because this whole laryngeal complex is being moved up and forward by the suprahyoid muscles, and also because this bolus is now a heavy gravitational pull and it pushes through the upper esophageal sphincter. The problem can occur, though, if the upper esophageal sphincter doesn't stay open long enough or if it doesn't open wide enough. In that case, you can end up with residual bolus in the pharynx, and that can become a problem. So we'll talk about that in just a second. So depending on what kind of body shape you have and what kind of food you're eating, your tube or your esophagus can differ between people. And so when you don't have a bolus in your esophagus, it's flat like an air balloon, like an animal balloon without any air in it. And we actually have 3 different sections. So we call this the cervical region up here by your cervical spine, your thoracic region, which is here in your thorax, and your abdominal region down here by your stomach. Up here in cervical region is your striated muscle. And down here in your tummy, stomach area, abdominal area, this is your smooth muscle. And if you remember, smooth muscle is for resting and digesting. This is not something that you have volitional control over. This is your visceral motor responses, type of control that you have. And in the thoracic area is where you have both striated and smooth muscle. So this is often the area that you will see esophageal cancer, because this is where the cells get a little confused about what their job is supposed to be when it comes to what type of muscle they are. Excuse me, got a little bit of a cold. So hold on one second. Okay, sorry about that. I had a little coughing fit. So as the peristalsis from the cervical, thoracic, and abdominal regions of the esophagus push the bolus down, it will eventually reach the lower esophageal sphincter, which is tight upon rest, upon contraction regularly, and then at rest it will open up and allow the bolus to go through, and the bolus will enter into the stomach for further digestion. So what you'll notice, though, is after the bolus enters into the esophagus, what happens is after the bolus enters into the esophagus, the UES closes again, because remember, it's supposed to stay closed. And that allows the bolus to continue to go down and not come back up into the pharynx, where we get what we call laryngopharyngeal reflux. And what allows that, what then allows us to be able to breathe again is the fact that everything returns to normal. So those closures that we talked about, the epiglottis comes open, the arytenoids move back, the false vocal folds open, and the true vocal folds open, and the soft palate lowers so that we can breathe again, even if our lips are closed. But we do have the option at this point in time to do oral breathing as well. So in summary of normal swallow, you'll notice that there's not oral prep stage that is represented in these pictures, but we do have oral stage moving into the pharyngeal stage, and here you'll notice the beginning of the epiglottis being able to come over top of the laryngeal cavity. Here we have true folds, false folds, arytenoids are coming forward, epiglottis is moving back. soft palate is moving up, and here's when the pharyngeal constrictor muscles, superior, middle, inferior, would begin to engage, along with the posterior movement of the base of tongue against the posterior pharyngeal wall to move the bolus down into the upper esophageal sphincter area. And again, here you can see the bulging of the posterior pharyngeal wall as it begins to help push the bolus down into the upper esophageal sphincter. Here, the bolus has already entered into the upper esophageal sphincter and it is moving down into the esophagus as things are beginning to come back to its resting point. And at this point in time, we regain our breathing pattern and we are able to breathe again as the bolus travels down through the esophagus into the stomach. Okay, so that was normal swallowing. How is everybody doing? Because I realize I'm racing, but I'm teaching this as if you've already learned this, because you should have already at this point in time learned this. If there's anything that is burning in your brains about questions for this, feel free to go ahead and write them right now. And then what we can do is, if it's relevant, depending on what I'm talking about, we can pick up those questions in the chat, or I can catch them at the end. Okay, so just kind of circling up. Thank you, Erin, for the thumbs up. Circling up about normal swallowing. All of this doesn't just happen though, okay? So I want to remind you that we have a brain and we have a nervous system, and that helps to control our swallow. So as a reminder, nervous system is made up of the central nervous system and the peripheral nervous system. I have another dance I teach my students. The central nervous system is the brain and the spinal cord and the meninges. Okay, did you see the jazz hands? Okay, so brain, spinal cord, meninges, and the peripheral nervous system is the cranial nerves and the spinal nerves. Okay, so when we talk about central swallowing system right now, I'm talking about the central nervous system, so the brain and the spinal cord. That also includes the brain stem. So brain stem, spinal cord, because remember the brain stem is going to be connecting the brain to the spinal cord. And as a recall for you, a review, the brain stem is made of 3 different parts. We have the midbrain, the pons, and the medulla, or MPM, in that order from superior to inferior. So the cortical structures, there's the outside squiggly wiggly part of your brain. As we go deep, those are called the subcortical structures. You might have heard those as the thalamic structures, where the thalamus is, right? And the basal ganglia. And then we move down into the midbrain, and we move into the pons and the medulla, which is the brainstem. And then we move down even further into the brain, into the spinal cord. The cranial nerves emerge out of the brainstem, and the spinal nerves emerge out of the spinal cord. So central nervous system being the brain, brainstem, and spinal cord. Then we have peripheral nervous system being the cranial nerves coming out of the brainstem, and the spinal nerves coming out of the spine, or the spinal column. Okay, is everybody following so far? So, excuse me. Given that we're talking about central nervous system, let's talk about the brainstem. Okay, so recall, if you will, that brainstem nuclei. There are 2 of them that we need to know for swallowing. Nuclei, as a recall for you, is a group of cell bodies. Okay, so if you think about, we have cells that have cell bodies, and then they have axons that send information out, and they have synapses that connect, or not, they don't actually connect, but they send neurotransmitters through a synapse, and then the dendrites of another neuron will receive those neurotransmitters. It will send an action potential through the cell body, down the axon, out the axonal projection. So more neurotransmitters are released into the synapse, and it just keeps going and going and going. Okay. But when we have a bunch of cell bodies together, that's considered to be what we call a nuclei. It's like, I like to think of like a bunch of tadpole fish, tadpole eggs rather. They kind of gel together in this like ball looking thing. That's my brain thought about what nuclei are. So I don't know if that helps you or not. There's also this principle when we talk about neuroanatomy. It's the word SAME, S-A-M-E. So sensory afferent, motor efferent. Okay. So I'm kind of doing a little neuro review. So I hope this is helpful for you. Sensory afferent is information is coming from the body up to the brain. So it's ascending from outside to inside, and motor information is descending. It goes from the brain to the body. And what is really helpful when we think about swallowing is, again, we talked about that anticipatory stage. We have a lot of sensory information that's coming from the body into the brain this way so that we can be able to sense about what's going on. But then that sensory information is processed in the brain. It sends our brain an idea of what we want to do when we want to move. Remember, movement means muscles, means motor, right? So efferent information. That's going to move from the brain because the brain has the idea, it has to make the plan, and then it has to execute what that movement looks like, sends information down to the brainstem. And from there, the brainstem is going to send information out through the cranial nerves. And in this case, because we're not talking about the big body. And when we talk about the big body, we're talking about spinal nerves. We're talking about the little head and neck, right? Which is the cranial nerves. So as the information comes down from the upper motor neuron in the cortex through the subcortical structures, it will synapse into that group of cell bodies in the nuclei in the brainstem. From the brainstem, it will send out the cranial nerves or the final common pathway. Those lower motor neurons will then connect onto the muscles at the neuromuscular junction. Those muscles will move, and that will be something like making you chew, or something like moving your tongue, or something like closing your larynx, right? All of those movements that we think that need to happen during swallowing, so that we now have more sensory information that's coming from our body that gets sent back up to our brain to be processed, and the cycle just continues over and over again. Now, I have to cough one more time, so please excuse me for just a second while I take a little break. All right, so as we move into this next idea about the brainstem, we have a brainstem that is sensory in nature and a brainstem that is motor in nature. So the first thing that we're going to talk about is the nucleus tractus solitarius. And this is the sensory swallowing center located in the medulla. And I see requests for the PowerPoint slides, and I am happy to get those to Zach, and he can distribute them how he would like, okay? So no problem for that. When we think about the sensory information as it pertains to the major cranial nerves of the swallowing system, we have cranial nerve 5, 7, 9, and 10. 5 is going to give us information sensory from the anterior 2/3 of the mouth other than taste. So touch, temperature, sensations like vibration, pressure, and pain, all from the inside of the mouth. We have 7 and 9 are going to be our taste receptors to the whole entire tongue, as well as 10 is going to give us sensory information that's coming from the uvula and the epiglottis, as well as the upper pharyngeal area, okay? So taste and touch, and we also want to think about how respiration and the cardiovascular system is going to be involved, because that really helps us understand how much breathing we need, how quickly we're going to be breathing, and the coordination between respiration and swallowing obviously is very important, because otherwise, if we are closing off the apnea or the breathing system when we're swallowing, and we're not able to get appropriate oxygenation or deoxygenation, then that can really mess up what is going on with our cardiovascular system, because the blood is not able to transport oxygen where it needs to. So all that being said is that we have information that is coming from the brainstem that is going to be modulating information that comes from the body up through the brainstem in a sensory manner, and sending it up to the cortical structures in the brain so that that sensory information can be processed. The other nucleus in the brainstem, also in the medulla, is called the nucleus ambiguus, and this is the motor aspect. So this is going to be what is controlling the information that's going through cranial nerves 9, 10, and 12. Remember, those are the only ones, excuse me, as it pertains to swallowing. And again, this doesn't necessarily mean cranial nerve 7 and cranial nerve 5 aren't motor, because they are involved, and they are motor for the facial muscles and for mastication. But we're just thinking about the pharyngeal stage here at this point in time. 9, 10, and 12 are going to be the major motor innervators that are coming out of the medulla. As a recall, if you got into the nitty-gritty of your neurology, when you think about where the cranial nerves are going to be exiting the brainstem, cranial nerves 5 and 7 exit through the pons, whereas 9, 10, and 11 and 12 also are going to be exiting through the medulla. Okay, so when we think about the nucleus tractus solitarius, the sensory system, and the nucleus ambiguus, the motor system, together, they're considered to be the functional swallow unit or the swallowing center. And so here's a picture of what this might look like for you. And again, here we have 5 and 7 coming out of the medulla, right? And up here, this is kind of the difference between where the pons and the medulla separate from each other. And then we have 9, 10, and we have our motor aspects over here. Now, don't think that just sensory is on one side and motor is on one side. These are actually bilateral, but if we had green and red on both, it gets very confusing for everything. So just keep in mind that we have motor on both and we have sensory on both sides. These are bilateral structures, just like we have 12 pairs of cranial nerves. We just don't have 12 cranial nerves. We have 12 pairs, okay? So keep that in mind. All right, so here's a really good overview of all the different cranial nerves and where they're going to the different aspects for different muscles. When we think about the subcortex and the cortical control, again, thinking about central nervous system, we have to have a plan in place, right? We have to have a plan to be able to execute the motor control. And the primary motor cortex, which is Brodmann's area 4, is going to be really where the voluntary control of our muscles is going to be the execution of the plan of movement. And then when we have information coming in from the body ascending up to the brain, it's going to be processed in Brodmann's areas 1, 2, and 3, which is the primary sensory cortex. And as a review, we have your longitudinal fissure, your lateral fissure, and your central fissure. Your primary motor cortex is going to be right anterior of your primary central fissure, and your primary sensory cortex is going to be right posterior. And when I say right, I mean directly posterior to your central fissure. We also have the insula cortex, which is right here in the lateral area, kind of near where the temporal lobe are. That can also help modulate some swallowing control as well, as it pertains to attention and memory and things of that nature. Oh, sorry, here it is, and things of that nature. The premotor cortex, or BA6, is going to help us with motor planning, and you all know that if you have other types of deficits in BA6, this can lead to apraxia of speech, limb apraxia, and again, apraxia of swallowing. If we have thalamic or basal ganglia damage, these are the subcortical structures. This can also be helpful for being able to understand different sensory information from food, things like carbonation, taste, some sour and sweet variations, and different textures. So as we're thinking about all of this, we have a really important neurologic control that we have to consider, and that's the cough response. The cough response is very important with being able to keep food or liquid out of the airway. And we have sensory and motor fibers that can help with this. Our sensory fibers, these have to be able to sense that something is going wrong in order to cascade a motor effect of a cough, to be able to actually be able to put those the diaphragm muscles and the laryngeal muscles of the intrinsic larynx to be able to move the vocal folds together, to be able to form a cough, to be able to expel anything that might have gotten into the airway. So when we think about the pathways for cough, we have several different central centers, if you will, that have cough response. So right here in the carina, and also down into the main bronchi and both of the lungs, which is why if you have an upper respiratory infection, you cough quite a bit, because you actually have sensors down in your lungs. If you have something stuck down in your esophagus and you feel like it's actually stuck right up here, it might actually be a little bit further down, because this cough receptor right here is going to make you feel like you have something in your lungs, but it's actually caught up here a little bit further, as well as this cough response that we have in our pharynx, which is going to help keep anything out of the laryngeal inlet, which we want to stay clear for airway. So this leads us to this idea of aspiration, especially silent aspiration. If you recall that penetration and aspiration, what they have in common is that they both have airway invasion. What's different is that penetration is airway invasion above the level of the true vocal folds, and aspiration is airway invasion below the level of the true vocal folds. So aspiration, once we're below the level of the vocal folds, you should be able to actually feel that through a sensory sensation, and then that would trigger a very strong cough response to be able to expel or eject that aspirated material. However, you'll see here that about 1/3 of dysphagia patients do aspirate without having a cough sign. So what that means is that your patient can actually be having food or liquid enter in the airway below the level of the vocal folds with no sensory response, and therefore no motor response either. This is really important when we think about this clinically, because this means that when we feed our patients at the bedside, there's a real possibility that 1/3 of those folks may actually be silently aspirating with actually no signs or symptoms from us. And so what we really need to think about or advocate from a clinical perspective is making sure that we have instrumentation for our patients so that we can actually be able to see inside their bodies and know whether or not they are having safe and efficient swallows. However, because there are some clinical signs of aspiration like dysphonia, dysarthria, some coughing after swallow or changes in voice, there's a possibility we might suspect aspiration, but we cannot confirm aspiration at the bedside. So it's really important to understand that, especially as new clinicians. So as we move into this idea of diagnosing swallowing disorders, and we've talked a little bit already about what that looks like at the bedside, we need to think about what might cause swallowing problems. So we have neurologic issues, a lot of mechanical issues, even someone just having an NG tube placed or a tracheostomy placed. There's a lot of different types of surgeries, especially cervical spinal disease, that can cause dysphagia just because of the mere placement of where that is in the head and neck. And this can be a real issue. The major issues that can be caused by dysphagia is aspiration pneumonia, which is when you have aspirated material below the level of the vocal folds enter into the airway and cause an infection in the lungs. We can also have malnutrition and dehydration. At the most extreme, these can lead to death. And so the morbidity and mortality rates in patients that have dysphagia is higher than those who do not. So when we're thinking about the oral prep stage, because this is the stage when we're thinking about the lips being closed and we're getting the bolus prepped, if we have difficulty chewing or food falling out of the mouth, those are going to be some of the signs that we have dysphagia at that stage of the game. At the oral stage, difficulty with food remaining in the mouth, forming the bolus, or moving the bolus anterior to posterior is going to indicate that we have an oral stage dysphagia. Pharyngeal stage dysphagia would be indicated by a swallow delay, an absent swallow, which might occur in a pontine stroke or a medullary stroke, again, where the nucleus ambiguus or nucleus tractus solitarius is, where the cranial nerves are synchronizing up with each other. If those are obliterated because of some type of brainstem involvement, then there's possibility there could be an absent swallow and perhaps a pooling of the bolus. And again, as the bolus moves into the esophageal stage, if it is staying there, if it's not going to be passing through the cricopharyngeus muscle in a timely manner, if there is impedance of that passageway through the upper esophageal sphincter, or it doesn't stay open long enough, excuse me, there's a real stage problem with the esophageal stage. So how do we assess dysphagia, right? This is the real key. There's lots of different ways when we think about assessing things for speech language pathology. And one of the things that we do is screening. The whole purpose of a screen is to determine, is there a problem? If there is a problem, and at this point in time, we think about the Yale Swallow protocol as one specific standardized screening that we can use that includes cognition, an oral mech exam, and a 3-ounce water challenge. These three things together can allow us to determine if the patient is at risk for dysphagia and at risk for aspiration, but it cannot confirm either of those. But if we do notice that a patient is failing one of these aspects, then they do have a risk factor involved for possibly having dysphagia, and that should trigger the next stage in the evaluation sector, which is the clinical swallow evaluation. During the clinical swallow evaluation, we're going to make sure that we are collecting a medical history through chart review and interview, or that we're going to complete a physical examination, which may or may not include giving patient PO trials or trials by mouth. And of course, you always want to make sure that you're doing proper oral care before feeding anybody by mouth, as well as doing a thorough interview about any possible allergies. We also want to think about how they're feeding themselves, and this is when we have a great opportunity for interdisciplinary care. And then we're going to think about any other type of additional tools like quality of life, functional measures, or patient-reported outcome measures. We have 2 instrumental swallow evaluations that we think about. We need to have these instrumental swallow evaluations because we don't have X-ray vision. We can't see inside the patient, and we cannot confirm aspiration without these. So this is a modified barium swallow study, which is an X-ray that is dynamic that you can see as you're swallowing, or the fiber optic endoscopic evaluation of swallowing. And this is the superior view using an endoscope that is dropped, and we are able to see a transverse plane of the laryngeal opening as well as the pharynx. Now, there are some differences between the modified barium swallow study and the fees, and I have a few of these listed here, and there is no right or wrong answer. These are both considered to be gold standard evaluations, and depending on what your patient's needs are and what you suspect clinically will help you determine which of these exams is going to be best for your patient. Now, after you have confirmed your patient's physiologic impairment using instrumental evaluation, you can appropriately provide a treatment plan. That might look like changing the diet or providing some type of feeding modifications. I suggest using the International Dysphagia Diet Standardization, or the IDSE Foundation, which you'll see listed here, or consulting with some other feeding specialists, occupational therapists, to provide any other types of modifications like a built-up spoon or things of that nature. We also may provide some recommendations for implementing postures or maneuvers. Some of these should be familiar to you. And I want to let you know that postures and maneuvers in themselves may not be helpful to actually fix the swallowing problem. They may be helpful to compensate. But what we really need to focus on is rehabilitative techniques, which can actually manipulate the physiology at the muscular level, help regenerate neural transmission, and be able to improve strength, duration, or being able to maintain swallow proficiency as patients go throughout the meal. I also don't want to forget about the importance of counseling as it pertains to swallowing. We are SLPs, we're communication specialists. We identify with disability, and we help patients be able to identify that swallowing does really have a huge impact on their identity and their quality of life. We have a huge role in providing prognostic considerations across the lifespan, so at the beginning of life all the way to the end. And there's several ethical concerns that can play a role as we begin to talk about different concerns and things of that nature with patients as it pertains to their swallowing. And we have a real opportunity to provide interprofessional collaboration. So that was a lot, all in 1 hour. That was basically a whole 16-week dysphagia class and review. So hopefully that was helpful for you. I do want to encourage you to go to the Therapy Ed website. That does have several different options for you in regards to the different office hours that they are suggesting. I'm trying to get back to where I can see you. There we go. Different office hours that they have for being able to review through the different praxis materials, as well as any other practice exams and how to order the practice book. So all that being said, that was your hour in a nutshell. And I'll be happy to take a little questions if you would like. Contraindications for the Shakir maneuver. Yes, Aaron, good question. So yes, any recent surgeries to the neck area, head and neck cancer, tracheostomy tube, any type of surgical incision would be a contraindication to the Shakir, as well as just the patient's inability to actually follow the directions. There's the isometric and the isotonic version of the Shakir. sometimes patients really just cannot manage that. If the patient cannot be lying flat on their back, that's another indication. Perhaps they have cerebral spinal fluid issues, blood pressure issues, cardiac things of that nature are some things to consider. So one modification to the Shakir is what is called the CTAR, the chin tuck against resistance, where you put the ball underneath your chin. And it's very similar, and it is backed by evidence. So that is another exercise rehabilitative that might be along the lines of Shakir, if that's something that you're looking for. I realize that this was really fast, but there was a lot of information to cover in an hour. So I hope it was helpful for you. Any other questions? Thank you. You're welcome. Like I said, you're welcome to email me if you, Zach, I can send you the slides. So if you'd like to share those, that would be fine with me.
Perfect.
Anything else?
Yeah, so if anybody would like the slides, please just drop your email in the chat, and I'll take note of those. And once I get the slides from Dr. Hazelwood, I will send them along to you. And if there are no other questions, just wanted to say thank you to Dr. Hazelwood for coming out.
Sure.
Fantastic discussion. I'm sure
My
everybody
pleasure.
loved it. And this is actually our last office hours for this semester. If you guys are interested in coming back next semester, keep an eye out for an email to regarding what the schedule will be. But thank you guys so much for being involved and engaged this semester. We appreciate it.
Good. Wishing you all the best as you enter into the end of your final exams, as you start your internships and you start your career. So you're going to make great SLPs. Looking forward to it.
Definitely.
Thank you.
Good night, everyone.
Good night.